Hello, good evening, everyone. Thanks very much for joining our webinar today. Today, we're going to talk about a new prosthetic system, which we call it Biofunctional Prosthetic System, a new era suction complete denture. So let's get started. So as an introduction, uh, we know that the suction effective mandibular complete denture is EMCD is being given great attention in the world recently. The reason is that not all actually edentulous or completely edentulous patients are a good candidate to have dental implant in order to support their prosthesis. So we can offer new treatment options for these patients, especially the patient who's having severely resorbed bridge and they cannot afford to go for implant treatment, maybe because of their budget or because of other contraindications. So this kind of treatment option is very good for them. So if you wear an ill-fitting denture, it requires a constant attention not to drop out during the mastication. So SAMCD denture is a well-fitting denture because it will relaxes the patients and it will enable them to enjoy their life. So what is the difference between the conventional denture treatment and the suction effective mandibular complete denture treatment? All of us know that conventional denture fabrication technique with the stick, compound stick, or green sticks, advocated by Dr. Boucher long time ago in the 1960s, is a far different from the suction effective mandibular complete denture techniques. So this conventional treatment theory is that the dentural flange, as we know, should extend to the muscle attachment to cover the maximum ridge's surface in order to get a denture stabilization. However, lately there are not many dentists who can teach accurate compound technique. So on the other hand, whether it's a maxillary or mandibular denture fabrication, the suction denture treatment emphasizes on and pay attention to the oral mucosa. So actually the main focus is on the oral mucosa. The maximum suction is acquired by having a tight contact between the denture base and oral mucosa and creating a kind of negative pressure between the mucosa and the denture base during swallowing. So swallowing is a very important functional movement during taking the impression for this kind of treatment options. Here is the comparison between the conventional denture and the suction denture. As we said before, conventional denture will focus and will target the muscle attachments, whereas for suction denture, it will focus on the oral mucosa to get the negative pressure. The purpose for conventional denture is to get a better masticatory performance, whereas for the suction, we will have better and enhanced suction. The concept for conventional denture, it means that we need to enlarge the denture base so it will cover more stress-bearing area, while for the suction denture, it will focus on the entire denture border seal, not to be compromised. The conventional technique is used by college educators, lecturer, and dental students, while for the suction denture, mostly it will be done and can be done by experienced dentists. How about the material? Actually, the material mainly will be focused using the compound for the conventional technique, and for the suction denture, mainly we'll be using a silicone material, silicone impression materials with different viscosities. So, for the primary impression or preliminary impression technique, the conventional technique will be the purpose of that one actually is to have a clear identification of the muscle attachment by applying stress on the mucosa, and the mucosa will be extended. Therefore, anatomical features of the muscle attachments will become clear. While for the suction effective denture, the purpose is to do the impression to reproduce the intraoral anatomical features of the closed mouth rest position with a minimum distortion, more to be like a static, pressureless. So for the conventional denture, pressure loaded impression will be utilized, while for the suction denture, we will be utilizing the less pressure or pressure-less loading impression technique. This is why also for conventional technique, we'll be focusing more on doing the open mouth impression technique. And for the suction effective denture, we'll be focusing on doing the closed mouth impression technique. How about the final impression for conventional denture? Actually, it's dentist-oriented method. Dentist-oriented method. It depends on the dentist itself. It's dentist-centered one. While for the suction effective denture, it mainly focus on the patient's functional movements. And for the conventional denture will be more like mostly open mouth impression technique, and for the suction denture will be closed mouth impression technique. For the conventional technique, we are focusing on the functional impression controlled by the dentist. It depends how the dentist will stretch the cheek, will stretch the lip, as do all these functional movements by himself. While for the suction denture, it will depend on the patient himself. He will do the dynamic functional impression without any kind of intervening by the dentist. For the conventional technique, we'll repeat the impression partially until completion. It means we do the section by section impression technique. While for the suction denture, we'll be focusing on doing it all in one shot, one time total impression. The impression outcome changes depending on the dentist himself. So this is why if we have a patient, we want to fabricate a conventional denture for him. If we have two dentists, mostly we'll be having two different outcomes. Why? Because it depends on the dentist dexterity, dentist ability, and even though they're using the same custom tray, also the impression will be a bit different from each other. While for the suction denture technique, the impression outcome is consistent with the same custom tray, no matter who is that dentist, because it's mainly focused and mainly centered on the patients themselves. The custom tray position. During the functional final impression taking, most of the dentists would have experienced to lose the correct custom tray positioning by repeating border molding multiple times because we are doing it in a sectional technique. On the other hand, suction effective denture or biofunctional prosthetic system impression technique requires to insert both maxillary tray connected with the mandible tray and take a closed mouth functional final impression. Therefore, the possibility of the tray displacement is very low and the accurate functional final impression can be acquired. This is why actually it's more accurate. Because the suction denture is, as I said before, is focusing on the oral mucosa and the conventional denture is focusing more on the muscle attachment. So how we get the suction mechanism for mandibular complete denture? Because you know that all of our problems during practice at the lower denture always having problems with the retention or stability or support. Upper denture, most of the time there is no issue. So maybe someone will ask us, okay, why always the retention of the lower denture will be compromised more than the upper denture? First of all, because the upper denture it has uh, a larger surface area than the lower denture, plus less muscle attachment on the upper arch if you want to compare it with the lower arch. This is why the chances for the denture to be destabilized in the lower arch is higher than the upper denture. So what are the suction mechanisms that need to be provided for mandibular complete denture? So actually, first of all uh, we have area number one, which is complete and total seal of the interior denture, base surface, and oral mucosa in the retromolar pad region. This is the primary seal. From now on, I'm telling you that the retromolar pad area is very important to record this area accurately because it's functioning in a way that it will compromise the denture stability. So the retromolar pad must be totally covered by the denture base. All of us before knows, oh, we should cover only 1/3 or 2/3 of the retromolar pad. No, if you want to get a proper suction for your lower denture, you need to cover the retromolar pad area completely. And I will tell you why later. So, initial process should start with the preliminary impression with the frame cut back tray. That tray, actually, the frame of that tray is cut at the retromolar pad area and also on the buccal shelf in order to record that area in a static state. No pressure. We don't want to apply pressure over the retromolar pad area. The second area is the number two. Number two, also seal above the retromolar pad secondary closure. So we have for the retromolar pad, we have two seals, primary seals and secondary seals. So for the secondary seal or secondary closure, the posterior border seal can be achieved by having contact between the buccal mucosa and the side of the tongue above the denture base where covers the retromolar pad. This is why you need to make sure for the lower denture at the retromolar pad area, the thickness of the denture is as minimal as possible. So we can allow the buccal mucosa and the side of the tongue meet each other and contact each other over the retromolar pad area, so the denture will be wrapped and the suction will be provided. So this area we call it actually PTC, buccal, mucosa, tongue side, and C is the contact area. Okay, number three area is the compensatory closure at the retromylohyoid fossa. As we can see here, a wall must be created to resist the tongue pressure applied when the tongue root presses against the lingual polish surface. This wall can be created by extending the denture border by 2 to 3 mm if possible beyond the mylohyoid ridge. Most of the time we see that the lower denture, the technician or the dentist, they will trim a lot at this area till it's not covering the mylohyoid ridge at all. And this is why the denture stability and the denture retention will be compromised and we cannot get a proper suction for the lower denture. So please make sure that this area, that the denture border is extending beyond the mylohyoid ridge at least by around 2 to 3 millimeter. Number four area, which is also very critical, it's the anterior exterior double closure in the sublingual fold region. With an abundance of spongy tissue in the anterior lingual vestibule, the contact between the denture border and the mucosa in the sublingual fold region is maintained in order to provide a stable and strong seal. As we can see here in the upper picture, that here we can estimate that the suction will be good because we have abundance of the spongy tissue. While for the lower picture here, we can see that during the examination, there is no abundance and it looks like a tent-like shape and more bony structure there. So the retention and the suction can be also compromised. Number 5 and 6, it's the anterior and exterior double closure in the buccal and labial area. Here we need to make sure that the denture flange in the buccal and labial area is already surrounded by the buccal and labial mucosa and the alveolar ridge in a proper way. So the denture will be wrapped and will be sucked inside with these tissues. So all of us know that everything starts from the simple intraoral examination. Simple intraoral examination. So the examination items for mandibular complete denture, we need to classify it, categorize it into two factors. The first one is the anatomical suction inhibiting factors, and the second one is the jaw relation inhibiting factors. So we'll see how. So sharing the examination of the mandibular suction potential among the clinical and lab side, this is why we need to have this examination or END form, one from the clinician and one also for the lab. So we will see what we have been examined in the patient's mouth and what we have got, what we have received from the primary cast. So this oral examination sheet is developed for a suction effective denture with minimum check items stressing on the clinical practice. It allows the practitioner to evaluate the patient if suction effective denture could be fabricated or not in just only 10 minutes at the first visit. So success rate of achieving satisfactory suction effective denture is considered to be about 87% by the well-trained dentist. Successfully screening the rest of 13%, which is considered as a difficult case, need to be utilizing the examination sheet, and this one will allow the initial consultation to be more effective and specific. This examination result is shared with the technician, allowing him or her to consider about the fabrication of the custom tray or denture teeth setting, thus being able to work with the dentist collaboratively, sharing the same treatment goal from the start. So, the suction inhibiting factor is categorized into two groups. First one, as I said, it's anatomical factor, and the second one is the mandibular jaw position factor. They are all measured by qualitative analysis, so no need to have a measuring equipment. Anatomical factor is divided into five items actually. We have the ridge form, we have the spongy tissue in the sublingual fold region, we have the space for the denture extension in the retromylohyoid fossa region, and we have also the bear-like shaped retromolar pad, plus we have the tongue retraction upon the opening of the mouth. Okay, so anatomical factor is divided into five items, and the case will be considered difficult case if there are more than two are marked as poor. So later we'll show you how we consider when it is going to be good, when it's going to be fair, when it's going to be poor. Also, for the mandibular jaw position factor, it's divided into three items. We have the jaw relationship, we have the mandibular jaw position, and we have the TMJ function. So it will be considered difficult. The case will be considered difficult if one checked at the most rightmost column or the what they call the poorer one. So it could be class 3 or unstable tapping point, or we have severe dysfunction with the pain in the TMJ. So anatomical suction inhibiting factors. We need to check actually the ridge. So first, extensive ridge resorption. If the ridge is resorbed extensively, the portal seal tends to break due to air invasion by movement of the denture on the ridge during the occlusion. It's considered good if the amount of the bone above the mental foramen is equal or more than that below. It's considered fair if it's less, and poor if the bone loss is right above the mental foramen. This is why it's very important to take at least OPG or panoramic radiograph before starting the suction denture treatment in order to evaluate the ridge. How about the lack of spongy tissue of the sublingual fold area? Strong border seal is generated by lingual flange being engaged in the spongy tissue. It's considered as good if bulging spongy tissue is appreciated when the patient is asked to close the mouth slowly from the open position. It is considered as fair if the bulge is minimum and as poor if it's firm and it looks like tent-like shape. How about the retromylohyoid space? Actually, if it's the complete seal is not accomplished unless the denture border is extended at least, as I said, 2 mm below this area of sublingual aspect of the retromolar pad. It's considered as good if the retromylohyoid space, which allows the extension of the denture border at least 2 mm below the mylohyoid ridge, is confirmed by using the dental mirror, as we can see in the picture. And if it is shallow, it's considered as fair, and if poor, if there is no space for extension at all. Strong retraction of the tongue upon opening the mouth. If the patient retracts the tongue strongly and unconsciously when opening the mouth, air gets in from the lingual flange edge of the denture and breaks border seal. The position of the tip of the tongue in relation to anterior area of the ridge is checked at rest position of the mandible or at the position with the mouth is slightly open. Because if we ask the patient to open wide open, what will happen? The tongue involuntarily will retract to the back side. If retraction of the tongue is less than 2 cm, it's considered as normal. If it's between 2 to 4 cm, is further retraction as a fair, and if more than 4 cm, it's even further retraction, which is a poor prognosis. How about the most important anatomical landmark? Actually, is the retromolar pad. The retromolar pad is considered to be the most difficult part to establish good border seal due to change of the shape of it during open and closed motion of the mouth. There are 4 examination items and each side is examined, right and the left. First, is there any firm fibrous tissue in the anterior region? The size, is it large or small? Third, the tilt angle of the retromolar pad will be shallow or steep. Actually, it will be considered shallow if it's 20 degrees or less. But if it's more than 20 degrees, the tilt is more than 20 degrees, it will be considered as a steep, which actually can give a poor prognosis. Also, the change of the shape during opening and closing motion of the mouth, large or small. If there is no check in poor, it's considered overall as good. And it will be considered as fair if there is one check in poor, and as poor if there are more than 2 checks in poor. So it will be considered like that. How about the suction inhibiting factors due to the mandibular position? Actually, it depends if it's a class 1, class 2, or class 3, but most of the time we'll be having problems with this jaw relationship of a class 2 or class 3. Large overjets tends to be provided in class 2, as we know, resulting in allowing a large play in forward-backward direction. As a result, the border seal will break by air invasion due to sliding movements of the denture on the ridge. The low tongue posture or position is often found in a class 3 jaw relationship, which makes the lingual border seal difficult for us. This is why we need to make the denture flange at that area a little bit thick so we can have a little bit close contact between the tip of the tongue and the denture flange or the dental aspect at the lingual side. Strong opening retraction by lower lip during opening the mouth contributes to dislodgement of the denture in class 3 as well. The other inhibiting factors due to the mandibular position is the unstable mandibular position. If mandibular position is unstable, the border seal also will be broken as air invades from the border due to the movement of the denture on the ridge caused by the occlusal interferences. In this case, discrepancy between the guided position, as the clinician will guide the mandible all the way to the centric relation, and the patient's habitual occlusal position, that which was already developed by the patient himself, need to be checked by guiding the mandible backward with the existing denture in the mouth if he's using a current denture. Another guiding method is first to have the patients open his or her mouth, touching the posterior region of the palate with the tip of the tongue in order to retract the mandible and make it go to the centriculation position. The dentist stands in front of the patient and hold the lateral side of the mandibular denture teeth in order to guide the mandible, and then ask the patient to close the mouth. Ask the patient to close the mouth, not to bite, huh? Ask the patient to close the mouth, keeping the tip of the tongue touching the palate or the soft palate. Then the mandible is guided backward and the discrepancy can be observed. If the discrepancy is more than 2 mm, the discrepancy between the centric relation position and the habitual position is more than 2 mm, it's considered that the discrepancy exists between the guided position and the habitual occlusal position. If the tapping point is unstable at the guided position, so it will be considered that the mandibular position is unstable. How about the other inhibiting factors due to mandibular position is the extensive temporomandibular functional disorder or TMD. Drastic displacement of the mandibular jaw position, which induce click sound, could generate occlusal interference, breaking the seal between the mucosa and the denture. As I said before, a suction denture will focus on the oral mucosa. We need to have the complete seal between the denture and the oral mucosa. If any factors inhibiting this one, it will compromise the suction. So we need to be careful. So we need to palpate about 13 mm in front of the ear hole, asking the patient to open and close the mouth in order to palpate the TMJ. It's considered as good if the both condyles move simultaneously and smoothly. It's considered as functional problem if one condyle precedes the other or one of the condyle deviates belatedly when it moves. It's considered severe functional problem if a click sound caused by abnormal movement of condyle disc or pain accompanies the system above. So in this case, what do we need to do? The treatment denture to correct the mandibular position is indicated if strong suction inhibiting factors due to mandibular jaw position are observed. In this case, we cannot tell the patient straight away, I can do for you suction denture. I need first to prescribe for you and fabricate for you a treatment denture in order to correct the mandibular position. Or we can suggest to the patient to have an implant supported overdenture. Sometimes would be indicated if a strong functional disorder such as click sound of the TMJ is observed. So the condition is poor. We can consider the treatment denture as it will be indicated to stabilize the mandibular position. Also, soft liner is recommended for sensitive mucosa, especially if the patient is having very thin mucosa and it's more to be uh, vulnerable and to have a heavy occlusal load, so it can traumatize the mucosa. So we need to prescribe or to have a denture with a soft liner. Light one soft liner will work as a cushion to minimize the harmful effect of the occlusal load over the mucosa. And cream type denture adhesive is recommended for the patient who's having dementia or dry mouth. So, available rules for success in complete denture treatment. Success in complete denture treatment is defined as follows. Maxillary complete denture never dislodged, and to achieve a suction effect for mandibular complete denture. Even if a great suction effective impression is taken, patients would have hard time to chew if the denture moves on the ridge due to poor intermaxillary record. On the other hand, the denture would function well enough even without suction effect as long as occlusal position is stable at the one point. This is why we used to say that occlusion is the governor of the denture stability. Always I tell all the practitioner, occlusion is the governor of the denture stability. If you have a harmonious occlusion, your denture will be at least stable. So intermaxillary record is the most important step, and the biofunctional prosthetic system offers predictable results. So what is the reason to recommend impression procedure at the closed position. Why we need to do the closed mouth impression technique? Actually, fabrication of the denture, mainly with the closed mouth functional impression technique, we can see here from the picture that when the mouth is closed and the impression is taken, the denture base prevents the deformation of the retromolar pad at the mouth, even when the mouth is open. While if you fabricate the denture using the open mouth impression technique, when the mouth is open, the retromolar pad is already stretched. So when the patient closes his mouth again, the result will be the invasion of the air due to the contraction of the retromolar pad when the mouth is closed. This one will cause the seal to be broken and the denture will be not retentive. So what is the process of doing the suction effective mandibular complete denture using the biofunctional prosthetic system? First, of course, we need to do the examination and diagnosis, followed by primary impression using the upper tray, lower tray, with the alginic using different viscosities. Plus, we need to take the preliminary jaw relation using the centric tray. The second session, we need to do the precision impression or the final impression using different viscosities of silicone materials. Plus, we need to do the MMR or maxillomandibular relationship recording using the Magnetometer. After that, we will do the mounting using the face bow and the recorded jaw relation. Then we will do the teeth setting, then waxing up the denture, then do the try-in for the patient. Then after that, we will process the denture, and then do delivery for the denture to the patient. So consultation. Uh, how to explain first we need to explain to the patient that the maxillary and mandibular suction effective denture success rate is around 90%. 90%. There is no treatment that can have 100% success rate. Explanation should never be indecisive, such as I don't know that the denture fabrication can be successful unless I try, but your suction effective denture will be 90% will be 90% successful according to my thorough diagnosis. Consequently, you will be able to eat effectively and speak clearly. This explanation will be the key for gaining the patient's confidence in you. And it's important to understand that there is no treatment that possesses 100% success rate. So this is a clinical case. This is a clinical case. As I said, first we start with the examination and diagnosis sheet. The examination items for mandibular complete denture, as I said, we have two groups of suction inhibiting factors. First, we have the ridge form, as we can see here from the picture, that the ridge form on both sides are in good position and good shape. Spongy tissue in the sublingual fold region, it's actually fair, less spongy tissue. And the space for the denture extension in retromylohyoid fossa region is good for both sides. And for the retromolar pad, actually the presence of the firm fibrous tissue in the anterior half is there for both retromolar pad, both sides, right and left. The size is also large for both sides. And the tilt angle is actually shallow, which is good. And the change during the opening and closing movement is small. So at the end, we have a good prognosis for the pear-like shaped retromolar pad on both sides. How about the tongue retraction? Actually, the tongue retraction for this case is actually normal, less than 2 centimeter. The jaw relationship, it's in a class 1, which is good. Mandible jaw position, the guided position and the habitual occlusal position coincide or they are within 2 mm of discrepancy. And the TMJ function is normal for both sides. But the patient actually complain of the existing denture that cannot provide the good chewing function. So here we will start with the primary impression of the maxillary ridge using the Accudent XD system from Evoclar. First, we need to measure the water because we are using a tray which is thermoplastic. We need to use a warm water over the 70 centigrade. We can mold the tray according to the shape of the ridge if needed. And I know here, in order to increase the retention of the impression material to the tray, here we can apply also a tray adhesive. I know that the tray is perforated already, which some people can say, oh, no need because it's already perforated. But in order to improve the adhesion of the alginate to the tray, we can also use the tray adhesive. Then we need to use to apply the syringe AccuGel alginate material, which is actually the light body of alginate material. Light body of alginate material can be squirted and be injected on from the buccal, labial, buccal again, vestibule, and also in the hard palate area in the middle. Then we load the tray with a high viscosity alginate material and then insert it in the patient's mouth. We don't do any kind of functional excessive movements. We just ask the patient to close. We can stretch a little bit of uh, the lip all the way down and ask the patient to do the movement of sucking on our finger. Then move the mandible right to the left, open the mouth widely, and close the nostril and ask him to blow out. And that's it. And we can see that the impression already there, and we already with the different colors from the purple to blue with the one sitting. How about the primary impression for the mandibular ridge using the frame cut back tray? If you can see here the frame cut back tray, that the tray already cut in at the retromolar pad area and also the buccal shelf because we want to record this area in a static state. We don't want to apply any kind of pressure over the retromolar pad area because otherwise it will change its shape, it will change the form. So we can apply the light body of alginate material all the way on the ridge from the retromolar pad area, ridge, till we cover all the ridge. And then we load the frame cutback tray with the heavy body alginate impression material, and then we put it in the mouth. Of course, here we ask the patient to close his mouth. We don't apply too much pressure. Ask him just to swallow and can say some sort of movement like ooh, e in a light motion. And we can see here after the impression taken that how much detailed the retromolar pad area recorded, which actually will contribute critically to the suction of the lower denture. After doing the primary impression of the upper and lower jaw, then we need to use the centric tray. Centric tray is used to record preliminary jaw relation, the jaw relation using the centric tray. So centric tray is from Evoclar Vivident. First, we need to measure the appropriate vertical dimension of occlusion between the two reference points from the tip of the chin and also the side of the nose. Then we load the centric tray using the putty, silicone putty on the tray. Then we insert it in the mouth and we put it on the upper arch. After inserting the tray in the patient's mouth, we hold the tray with the left hand and secure the tray on the maxillary arch. Then we guide the mandible with the right thumb to the centric position to close on the tray. And we ask the patient to close slowly, and we let the patient to close slowly until the VDO or vertical dimension of occlusion position that was recorded previously is reached. We don't ask him to over close. Then ask the patient to swallow in order to make sure that we're already in the centric relation position. And after the sitting, we need to place the silicone putty also on the handle in order to record the horizontal line and the midline. This line will be the reference for the mounting on the articulator. So the maxillary arch impression with the centric tray already has been recorded. Mandibular arch impression with the centric tray already recorded. In order to make sure that the primary cast fitting into this impression that has been used with the centric tray, we can cut the excess material to fit the models. Then the models are fit to the centric tray bite, and then we mark the horizontal line and the midline on the silicone putty to the models. This one will allow accurate model mounting on the articulator. Then we use the UTS 3D face ball and articulating mounting. Here we use the semi adjustable articulator, which we call it the Stratos 300. There are the 100, 200, and 300. 100 mainly is used for the lab, and 200 and 300 is used in the clinic. And we can see that this kind of articulator, it comes also with the horizontal guide, and also it comes with the adapter in order to allow us to mount the primary cast on the articulator. So the custom tray designed for the maxillary that has a good condition, we need to make sure that basically we need to outline for the custom tray should be marked approximately 2 mm above the deepest part of the mucobuccal fold. Then posterior border should be outlined with the line created by the nose, blow effect, and line zone. So, and of course, the excessive papilla is very important landmark area, fovea palatina, the tuberosity, and the Rogis. And the outline of the labial area should be drawn 3 mm above the deepest part of the sulcus, because the upper lip and the orbicularis oris will move more than the soft tissue in the posterior area, so freedom of the space should be applied. So for the lower cast or lower arch, we need to follow the outline of the retromolar pad. Of course, here we can divide it into 3 parts. Of course, there's a very critical area which we call it the sumia sinew, which string, which has been named after the name of one of the Japanese uh, doctors who discovered this one. So we need to avoid this one. We need to relieve it. So avoid the sumia sinew string at the root of the retromolar pad. And of course, we need to draw a line at the most inferior point of the mucobuccal fold, which will cover the buccal shelf. Also, we need enter into retromylohyoid fossa region, 2 to 3 mm past or beyond the mylohyoid ridge in order to get a proper suction. And we need to avoid the buccal frenum by providing the notch there. And also the lingual frenum. So as I said before, please, we need to observe this one for any complete intentional patients. Wherever it's there, we need to avoid this one. We call it sumia sinew string. This is why the denture should be relieved at this area to provide a proper notch, so it doesn't disturb the retention and the stability of the lower denture. Here we can see that the clear sumia sinew string is observed when we stretch the cheek, the buccal mucosa, stretch it outward, and we can see that this is string. So need to be relieved, but some patient, this one is not clear. So also we need to block out with the wax for the ideal mandibular ridge condition, sublingual fold area, while fabricating the suction effective custom tray. Wax block out need to be provided on the sublingual fold area. It's very important to reduce the excessive impression pressure over this one, otherwise the patient will have pain. And also the top of the ridge also should be relieved, and the mentals muscle attachment area also should be relieved. The top of the ridge and the fibrous tissue on the first half or the anterior half of the retromolar pad also need to be blocked out with the wax. This area that cannot be altered by any pressure. Of course, the incisive papilla should be also blocked out or relieved, along with the palatal rugae. Also the top of the ridge, this is the area that cannot be altered by the pressure. So maxillary and mandibular custom tray bases should be fabricated with the resin-based material while following the designing outline, and the gnathometer need to be installed. Gnathometer actually it's a device used to record the definitive jaw relation between the upper and lower jaw. Actually, they are using the Gothic art tracing technique, where when we do the recording, we will have a shape like an arrow, and the tip of this arrow actually is the centric relation position, or most of the time also will be the tapping point of the patient closer. So 7 ideas for custom tray fabrication need to be achieved for mandible denture suction. The first one, we need to cover the retromolar pad with a thin layer of the tray material in order to get the PTC point, or the buccal tongue contact point, where the tongue side along with the buccal will cover the retromolar pad, uh, and then we'll get the proper suction. And of course, we need to avoid the sumia sinus strain. Uh, Also, we need to provide a concavity form from the second molar area of the polished surface to the retromolar pad. Uh, and also, we need to place the bite frame of the gnathometer need to be mounted with the white plate in the middle of the ridge, not more to the buccal, not more to the tongue. And also, we need to provide a sufficient tongue space by providing a proper concavity. And also we need to provide a proper concavity surface around the base of the tongue area, so the denture stability won't be disturbed. And the last one is to provide concave area at the buccal incisal area, especially between the lower lateral incisors. As I said before, this is the PTC point, buccal, tongue side, buccal mucosa, tongue side contact point. As we can see that the denture here should be as thin as possible, so the tongue and the buccal mucosa meet each other above the retromolar pad area. And we need to know that the maxillary denture custom tray thickness also, it follows also maxillary and the lower maxillary and the mandible. They follow the ridge resorption. So the higher the ridge resorption, the more thick the custom tray will be, and vice versa. So the buccal shelf area, the tray should be thick enough to support firmly. And for the retromylohyoid ridge area, the tray should be thin, not to interfere the base of the tongue movement. And at the retromolar pad area, the tray should be thin in order to get the PTC point. And for the sublingual fold area, the tray should be thick enough to get maximum sealing area. And for the lower anterior region, it's a kind of option. If the anterior vesicle is shallow, the area between 3-2 and 4-2 between the lateral incisors should be thicker in order to provide better lip support. So this is very important to have a proper technician who knows how to fabricate this kind of denture, because even the technician, they should go under a proper training in order to know how to fabricate this kind of denture, because it has a different concept. So gnathometer should be mounted. We check the horizontal line, camber's line, as we know, need to be checked. Centric tray bite is not perfect here, so we may not be aware that there is a large space under the tray, even though the bite registration seems to be perfect. If the space between the upper and lower tray seems to be small due to the error, the final impression can be proceeded with the added wax in order to make even pressure towards the ridge when taking the precision impression. However, the trace shows large space or large discrepancy. The gnathometer need to be reset. So how about the way we take the final impression using the custom tray? As I said, we need to do this one in a closed mouth impression technique. That means that both custom tray should be in the mouth whenever I'm doing the final impression. So we need to use the heavy body. Most of the heavy body need to be used to do the border molding for the upper impression, final impression, and the light body for the final impression. So first we need to apply the tray adhesive to the entire tray, interior and exterior surface, except for the palatal area. Then we put the heavy body in the middle of the hard palate to work as a stopper. Then we do the border molding with the operator's fingers movement. We pull the lip a little bit down and cheek muscles down according to the functional movements. And of course, the lower custom tray is in the mouth. And we instruct the patient to move the mandible right to the left. This will prevent the maxillary tray buccal area from touching the coronoid process. And also the border molding by the patients, we do the functional movements like that. The patient to swallow, to say ooh, e. Then we get the finished border molding. Of course, we remove the X if there is any pressure points. Then we take the final impression or the wash impression using the light body silicone material and we repeat again the functional movements. How about the one for the lower denture, lower section denture? Of course, we need to use the heavy body to do the border molding. Then we need to use the monoface at the same time, or the medium body for the retromolar pad area, because we cannot use the heavy body over the retromolar pad area because we are afraid that we will disturb or we will change or we will deform the shape of the retromolar pad. So it's always preferable and advisable to use the monoface for the retromolar pad area. And of course, we will use the light body silicone materials for the final impression. So we place the Vaseline on the posterior area of the maxillary final impression in order to make sure that the mandibular impression doesn't stick with the upper impression together. Monoface type impression material that is more flowable than the heavy body impression material should be applied to the retromolar pad area in order to prevent the shape distortion. Following that, we use the heavy body impression material on the border. After the tray is inserted in the patient, we ask him to do the 5 fundamental suction denture movements. What are these? We ask the patient to say ooh, 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 e. Then ask him to swallow. Then we ask him to push the lower tray with his tongue forward. And then we ask him also to wet the lower lip using the tip of the tongue. And the final impression after that can be also done using the same functional movements, the 5 critical functional movements. And for the post-dam area, in order to enhance the suction effect of the post-dam area, we can place the monoface type of impression along the posterior border of the maxillary impression. After inserting this in the mouth, the patient is instructed to bite with a gentle pressure and swallow. The patient is instructed to wait by applying this gentle pressure until the impression material is completely set. This technique will allow to acquire the tight posterior seal for the maxillary denture. After we finishing the upper final impression and the lower final impression, we need to mount the Magnetometer in order to get the Gothic arch tracing method so we can record the definitive jaw relation. So before Gothic arch tracing with the Magnetometer, let's reconfirm by using the phonation and the freeway space measurement. The screw of the Magnetometer is turned with the screwdriver and the height is secured using the sticky wax as we can see in the picture. And the figure we see here that we have the shape of arrow, and the figure shows that the tapping point are observed 0.5 millimeter anterior to the apex point. The mandibular movements disorder can be detected by relatively small Gothic arch tracing figure. So if we have a small size of Gothic arch tracing, it means that the patient is having some dysfunction or some TMJ problems. And the larger the Gothic arch tracing is, the more healthier the TMJ will be. So how we do this one, we put the upper custom tray, the lower custom tray, along with the gnathometer in the patient's mouth. Then we don't guide the patient by our hands. We just instruct him after training him many times to move the mandible backward, forward, tap, tap, backward, forward. Then from the tapping point can move to the uh, right side, then tap again, left side, then tap again, backward, forward, till we get the shape of the arrow. So the tip of this arrow actually represents the centric relation position. And also we can check if there's any big discrepancy between the tapping point, where the patient open and close his mouth habitually, and the centric relation position. So if all secure, then we put both together and we put the plate in order to fix the position of the centric relation, and then we can inject the medium body between the both custom trays in order to take all one shot the upper and lower final impression after recording the Gothic arch tracing. So then we do the articulation using the Stratos or semi-adjustable articulator. And of course, using the Facebook for suction denture, it's optional, but also it's recommended. But if you're not familiar with doing the Facebook, it's not actually mandatory, but we always advise to use the Facebook. Then, of course, we need to know that the reference lines for artificial teeth arrangement, all of us, we know that all the teeth, especially the lower posterior and anterior teeth, should be arranged on the crest of the ridge. Then we do the teeth arrangement, anterior and posterior. Uh, then we can do the denture try-in in the patient's mouth. We make sure that the patient is having the pulse occlusion. Actually, my advice to all the practitioner, if you have a patient who's having severely resorbed bridge, the type of occlusion recommended for him actually is the lingualized occlusion. Why? Because the lingualized occlusion will give more stability for the lower denture, plus it is more aesthetic than doing the monoplane occlusion, the one with a 0 degree cusp. So lingualized occlusion, it's where the upper palatal cusp only will be occluding on the lower posterior teeth or groove. Then we need to process the denture using the injectable technique. Not like most of the time, we know that we use the compression molding technique. But for the suction denture, we always recommend to use the injection molding technique, because that one, it has a zero polymerization shrinkage. So whatever you have done during try-in was perfect, it will be the same thing after processing. So technically and theoretically, no need to do any kind of selective grinding. And then the denture is already processed and polished, and this is how it looked like. You see here that on the lower denture, we already relieved the sumia area. Yes, and that's it. My advice to all of our practitioner, actually, if you want to learn this kind of technique, please, you need to read more about the biofunctional prosthetic system. It's technique sensitive. But if you, the more cases you do, the more experience you will be, and the more the success rate will be. And of course, you need to pick up, and you need to pick a proper technician who is familiar or who already been trained to do this kind of denture, because not all of the our technician, with all the respect, they are familiar of this kind of technique. So I know that also the price wise, the cost for the suction denture will be higher than the normal one, because the technician already have gone undergone special training, and it needs special equipment, especially the injection compression, injection molding technique. And of course, you need to use the centric tray, you need to use the magnetometer, and so on. And please, if you have any inquiries, you can contact us at any time. And thank you very much for joining this webinar, and hope you enjoyed this webinar, and see you later. Thank you very much. Bye bye.